Dear nephrologists everywhere, welcome you all in this session of the Universal Expert Studio. My name is Hussein Shaisha. I'm professor of nephrology at Urology and Nephrology Center, Mansoura University. Today we have two eminent speakers, Professor Hisham Al-Sayed, professor of nephrology at Ain Shams University, and Professor Tariq Fayad, professor of nephrology at Cairo University. And after the break, we are going to discuss with you a very hot session about the innovation of dialysis, and we'll come back after the break. Dear nephrologists, welcome back in our session of the Expert Studio. Today we are going to discuss the innovation of dialysis. Let me just to welcome Professor Hisham Al-Sayed, professor of nephrology and the chair of the chapter of dialysis at the Egyptian Society of Nephrology and Transplantation Society. You are welcome, Professor Hisham.
Thank you very much.
I'm sure that will
it's
be
my pleasure to be here with our colleagues, yes.
I'm sure that will be a very interesting session.
I hope so, yes.
Because we know your caliber in hemodialysis and the establishments in dialysis you did.
We will highlight some of important points updated, yes.
If
sure.
you allow me, let me to start with this
Yes,
question.
please.
Why hemodialysis? Why you are interested in hemodialysis?
Hemodialysis is a life-saving procedure. It's about 3 million people all around the world are in need of dialysis. You cannot miss even such session. Only one session you cannot miss. So if you don't have a dialysis, you will lose at least 3 million now and 6% globally. And if you look back to chronic kidney disease, you find that more than 850 million people suffering from CKD. So it's exactly like an iceberg. If you see the top of patients' need of dialysis, you will find more and more patients is still waiting to starting dialysis. So dialysis procedure is important. It's a life-saving. We have to improve the dialysis quality in order to live as normal as healthy people. And it's expected to be in 2025 more than 5 million patients on regular hemodialysis. So we have globally around 6%, and if you put that on all together, you will find more than 5 million within 4 or 5 years.
Through my career in hemodialysis practice, I witnessed major achievements and advantages added to the hemodialysis practice and machines and filters. I'm sure today that you will highlight what is the most important points in the evolution of the history of dialysis.
Yes.
And I know that you are interested in the digital health and
yes.
digital care.
Yes.
I'd like to hear from you about this point.
Actually, it's a world, and now at that time, exactly, we are in need of a digital platform for servicing patients worldwide. It's not only for dialysis. We have at least 5 categories of digital service. We have a teledialysis procedure. You can manage your patients. You can manage your patient far away. You have a telemedicine. You can examine, record.
Excuse me, Dr. Hisham, telemedicine is very fantastic nowadays because,
yes,
we are living in the Corona
COVID,
era.
yes.
And I think telemedicine become a very hot issue nowadays.
Yes, exactly. That's what few months ago we are talking about telemedicine, but it's an optional. Now it's a must, because every day you need to remotely control the therapy, especially if you are controlling multiple areas at the same time. And in such conditions of COVID conditions, you should be protected as well. So I think telemedicine and teledialysis, it's a time to start at least professionally. And if you look again, billions of dollars have been paid as an investments in the medicine and telehealth conditions, as well as more or less of you call that mobile health, which is an application that records every tiny conditions into your patients. As well, you have the precision medicine, and the precision medicine is something different, like personalized medicine, and both of them in the same pocket. So precision medicine and personalized medicine as well is needed, and of course artificial intelligence. The role of artificial intelligence in the field of nephrology is expected to grow through the following years, because a lot of data coming from everywhere in the world, even tiny information is important. So we are moving now from the technological field, from just recording data into controlling this data into a very big data, which is called big data value, and then you have to rearrange it, what's called the artificial intelligence. So this is the major
and I think
categories of telemedicine and teledialysis and innovation in information control and communication technology.
And I think if we promote telehealth and telemedicine, I think the ethics of the telemedicine and the telehealth will be on the top of the surface, because we should ensure safety of the data and to provide all what we can do to protect the patient's records.
Sure.
So we'll continue our discussion after the break.
Okay.
Welcome back. We are continuing with Professor Hisham. It is a very interesting topic. And I hear from you the 3pH.
Yes.
What 3pH, Professor Hisham?
3pH is my approach. It's my own approach. It's just to understand the kinetics of dialysis and your philosophy based on what to treat your patient.
We usually love mnemonics in medicine because it approximates the meaning.
Yes, if you look with that, yes.
So what are the 3pHs?
Yes, okay. The 3pH, I put that in this slide just to remind everyone who are going to treat his patient, he should think by a philosophy of therapy, and is controlled by personalized medicine. So no one size fit for all. You need to personalize your therapy. If you look to this slide, you have a 3pH, which is the physiology and philosophy of therapy and the physics of dialysis membranes. If you go to the solid flux, understanding the cellular and non-cellular compartments and the toxin, where is the toxins and which concentration of the toxins? Is it inside or outside the cells? Is protein bound or not? What is the generations of toxins limits, and it exceeds the dialysis prescription or not? And if you look for the physiology for that issue, you can manage accordingly uric toxins accumulations and the blood and extracellular compartments plus the cellular compartment. So if you need, for example, to remove urea, as an example, which is hugely distributed through the blood, the cells equivally, so you remove it easily. But if you look to the phosphate, for example, it's mainly intracellular. So the kinetics here in dialysis needs much improved approach, prolonged time, higher flux, and etc. And following that, if you understand the solid flux in physiology and you promoted that in the philosophy of therapy, you go to the physics, which is the dialysis membrane or the dialysis prescription.
I like the term philosophy
Yes.
because I think our philosophy, when we think of dialysis, is to try to simulate the natural kidney
Sure.
as we can.
Sure.
So I'd like to hear from you, what do you mean by philosophy for dialysis?
Philosophy depends partially on the first is the no one size fit for all. So you have to manage your patient by his disease, not by the global dialysis prescription. And this is exactly the philosophy. You may need the patient 3 times a week and needs 6 hours each session because he has hyperphosphatemia or have retention of uremic solids, which is mainly intracellular. You need more prolonged time. On the other side, you may need incremental dialysis in other patients. You need only 2 sessions, probably 3 or 3.5 hours, because he is just beginning of dialysis and you're starting to do dialysis, but preserving the residual kidney function.
And sometimes you have a patient with heart failure who cannot withstand long sessions, so intermittent, repeating, more frequent sessions.
Yes, that's exactly.
Okay.
And on the other side, the solute flux, what is the kind of solids you need to remove from the dialysis? If you need to beta-2 microglobulin, you may proceed for hemodiafiltration or extensively prolonged dialysis with hemodiafiltration as well, or home dialysis or nocturnal dialysis. This is the physiology and the philosophy of this therapy in order just to control all the patient need. Here, this is the slides that discriminate the personalized medicine from one size fit for all.
The physics of the dialysis, do you like to discuss the physics or?
Yes, physics of dialysis, it's absolutely physics. You have a dialysis membranes, and dialysis membranes has a specific characteristics, synthetic models, and you have a porosity, and the porosity can permit solid removal, and you have different flux, and even different flux can remove definite molecular weight. So if you have a low flux, which is nowadays going down and is not required in most of developing countries to be used, if you have a high flux, you can remove middle molecules. You can remove up to 20 or 30,000 Dalton in molecular weight. And if you go to superflux or the medium cutoff dialysis membrane, you can remove
I
up
think it's
to
very,
50.
very important point, because this is one of the most important innovations done through the last decade on dialysis, is to have high flux and superflux. I want just to know from you what's meant by high flux, the cutoff point for high flux,
Yes.
and the superflux, according to the molecular weight of the molecule that we are
Okay.
going to remove.
The cutoff is defined as the Stephen coefficient criteria of the membrane, which equivalent to 0.1, which is meaning that beyond this molecular weight, you cannot remove toxins. So the low flux is around 5,000 Dalton. The high flux is between 20 and 30,000 Dalton, while superflux and the medium cutoff dialysis membrane, you can remove up to 50,000 Dalton. So you are upgrading the molecular weight can permit from the dialysis. And this is simply by the porosity of the dialysis membranes.
And this will be translated into modality, hemodiafiltration and expanded dialysis. Is
Yes.
there a difference between hemodiafiltration and expanded dialysis?
Yes, it's both of them are on the same target to remove, but one depends on the pressure, the transmembrane pressure, high, just to dragging force from the dialyzer or the blood to the outside, and this is the mode of hemodiafiltration, whatever it's post-dilutional or pre-dilutional. While the expanded, meaning expanded is expanded range of molecular toxins that could be removed, and this is using medium cutoff. Please be aware that you cannot mix between both of them. So you cannot use expanded dialysis and hemodiafiltration, because both of them will have a huge albumin loss. So this is a technique, hemodiafiltration separately, and expanded is a technique separately. Don't mix between both.
And which one of them you find it's more advantageous?
I think the expanded dialysis is still growing in the market, and the clinical review is not too much about that, just a very few cases recorded. But it seems that it's an absolutely important in some specific disorder. For example, in the COVID state we have here, you have to remove cytokines for the cytokines storm. And the cytokines range between 17,000 Dalton and above 35. So the modality of removal of cytokines, whatever, is a prolonged session like CRRT or a medium cut-off dialysis or an expanded removal of toxins by the porosity of the membrane.
Really, you touched a very important, very sensitive
Yes,
issue.
it's out issue. Yes.
And I think that we will close the session by asking you about certain issues
And the COVID.
For COVID. But so long as we are speaking about the flux, here I have a question to Professor Tariq Fayyad, Professor of Nephrology at Cairo University. The most common complication witnessed by the patients in hemodialysis is hypotension. We would like to hear from you about the management approach and your advice and the tips to the nephrologists.
Yeah, this is a good point. It's a huge point. Most of the patients can suffer from intradialytic hypotension, but the point is those are chronic renal failure patients and they have hypertension and they are on already antihypertensive drugs, and it should be modified. It shouldn't be stationary or stable for weeks or months. So the point is it should be modified in order to avoid the hypotension. It should be kept on the hypertensive side in order to allow you to do the ultrafiltration in order to achieve your dry weight.
So it is a very interesting point. Not to be rushing in treating hypertension by antihypertensive medications.
Combinations of
because by this way, this will prevent from reaching the dry target body weight.
Because we will enter into a vicious circle. The
Okay.
patient will go into hypotension, then they will give him saline, and he's going to be, and so on.
I am personally very interested in the cooling of dialysate.
Yeah.
That's why we have many research projects about cooling of dialysate.
And
What
this
is
is
your opinion regarding cooling of dialysate and how to do it to reduce interdialytic hypotension?
I think it's a tool in order to manage the situation, that you decrease the temperature of the dialysate in order to avoid vasodilatation and hypotension. So it's a smart way. It's a smart way, and it should be applied, and this knowledge should be transferred and propagated as a tool.
So as you said, it is very smart because it costs nothing.
Yes.
Just to reduce the temperature,
temperature
of
of
dialysate
the dialysate.
by 0.5 degrees centigrade below the core temperature to be tolerated from the patient.
Yes, and I think as well the dry weight, the ways they measure the dry weight, it shouldn't be stable or stationary all through. You know, sometimes in summer you sweat, so the dry weight is changeable, and this is going to be projected on the ultrafiltration. When your dry weight is stable and then you need ultrafiltration more, then he's going to enter into hypotension and la la la.
Thank you very much, Professor Tariq.
Thank you.
Yes.
We have to mention that cooling the dialysate is a positive effect for blood pressure and negative effect of clearance, because if you go down 36 blood dialysate cooling effect, the movement of solids from the blood to the dialysate by diffusion is affected. And in addition to what's perfectly described by Professor Tariq, if you look to this slide here, the innovation here in dialysis looks exactly to what you need. And if you put that in hemodialysis, that improve quality of life, and importantly, you don't need to prevent the organ damage. You have to prevent the organ damage. And one of the major organ damage is by hypotension, what is called organ stunning. So hypotension and organ stunning, decreasing blood flow to the brain, decreasing blood flow to the heart, to the limbs, and to the intestine. So you can find your patients having strokes, have myocardial ischemia and infarction or fibrosis or hypertension, intestinal ischemia as well, maybe infarction as well. So this is a very important intradialytic hypotension to be very well controlled.
A very interesting addition, Professor Hisham. Cooling of dialysate is of no cost, but add a lot of advantages. As you mentioned,
Sure.
reduce mesenteric ischemia, improve cognitive dysfunction, and the only disadvantage is a reduction of dialysis.
Slightly,
adequacy. Yes.
be compensated
But
by blood flow.
A form of weakness.
but-
in this.
Yeah,
There
yeah,
are-
it's a tiny diffusion is a tiny clearance, and you can improve it by blood flow.
But I think you agree with us that
Sure.
it is a very nice modality.
Sure.
And I remember a study to assess the effect of cooling of dialysate on the cognitive function. They tested cognitive function by functional MRI, and they found improvement even in the brain by cooling of dialysate.
As well in the myocardial blood flow, you can test the myocardial blood flow during dialysis.
In this slide, I see the preserving residual kidney function.
Yeah.
And I would like to hear from how to keep the residual kidney function and to preserve it. What are the modalities you recommend, Dr. Hisham?
In order to preserve your kidney function, I think when you start your patient's dialysis first sessions, you have to manage it accurately, because usually patients start dialysis with a urine flow. So if you have a urine flow, you have to keep in mind to keep this urine flow above 500 milli per day. So in my opinion, if your patient is starting dialysis and still have a urine flow and residual kidney function, you may have starting incremental type of dialysis. You don't be aggressive in dialysis. And wait for the patient every 2 weeks to control his metabolic profile, anemia, phosphate, acid pH, everything on the patient, fluid overload. And if you still can control that on twice weekly dialysis, go ahead and reevaluate every 2 weeks. This is very important.
If you allow me here, just to allow incremental dialysis, we have prerequisites. We should check residual kidney function every month. We should look at the patient symptomatology.
Yes,
nutritional
it's about
status.
it's about 10 points you have to
Yes.
fulfill. At least you have to check the 10 points.
And
of
I think the
incremental.
most important is to have residual urine. So
Number one is to have the urine output.
Yeah.
Exactly.
And if the patient is overloaded, I shouldn't think of residual kidney function. I should do that.
You have to go dialysis thrice weekly or over augmented dialysis. You may proceed. Some patients, when starting dialysis, may need augmented dialysis because they are very catabolic. But some patients are incremental dialysis. It's fine. So it's a
Precision medicine.
yes, it's a precision
individualization.
medicine. It's
like
not a fixed. Yes.
So let us to have a break with Professor Hisham.
Okay.
Welcome back. I think this session is very hot. Professor Hisham, you raised a lot of issues.
Yes.
And I think Professor Tariq will have a very interesting point to discuss with you.
Yes,
Professor Tariq.
actually, you mentioned several times during our discussion now the precision medicine and the individualization. What about personalization in hemodialysis?
Yes, that's a good question. Thank you very much for highlighting this issue. We are calling for that several times. You have to personalize your therapy. No one size fits for all. And if you look to this slide, for an example, at any group of patients, 60,000 or more in the population of Egypt on regular dialysis. And you have to put your plan, you have to put on risk assessment, which means that the criteria of your patients, his serum albumin, CRP, hemoglobin, phosphate, pH, everything. You have to put the model of your patients on the screen. And then you have to plan your therapy. And after planning your therapy, you have to monitoring your therapy. Because planning does not mean management. You are just planning. And if you reach the goal or not reaching the goal. And you can individualize patients into groups, high risk, moderate risk, or low risk. So you can, grouping the patients into one basket is not advised, and you have plenty of interchangeable therapy. You can change the dialysate temperature, dialysate composition, and you can change the flux and convection, hemodialysis filtration, not for all sector of patient will be beneficial or not. And you can extend the dialysis time. You may be need in 5 hours, 6 hours, or 3.5 hours for each individual patient.
If you allow me,
well.
Professor Hisham, I agree with you 100%. The major problem that can reduce the issue of personalized hemodialysis prescription is the template of in-center hemodialysis.
Yes.
And when I did my the research about dialysis adequacy, the statement was we should deal with dialysis like we are dealing with antibiotics, to calculate the dose according to the patient demographics. So we have 5 patients who are dialyzed in the same time. This patient dialyzed 3 hours, this patient 4 hours, 5 hours, 6 hours. Blood flow is different from patient to patient. So this is the philosophy of performing dialysis, is to individualize our approach.
Sure.
According to the patient demographics.
And it's a successful therapy, yes. So this is, in general, we have key points should be in attention when you are managing your dialysis patient, putting on all the comorbidities, its nutritional status, his nutritional status, the inflammatory biomarker, the time frequency, and even so you can have more or less flexible in prescribing the dialysis to each individualized patient.
One of the important issue is fixed dialysate concentration. This reduces our performance to do personalized dialysis.
Sure.
Because we want to change dialysate composition, and what we have is fixed dialysate formula.
Yes, exactly. And this is, to my opinion, I am against CDDS, Central Dialysate Delivery System, because if you are using CDDS, you don't have an interchangeable composition of the dialysate. You are built on all-in-one in the dialysate. So I think patient needs higher magnesium, patient need lower calcium, patient need potassium 3 millimole, patient need 1 millimole, and everything is changeable according to patient needs.
You mentioned magnesium.
Yes.
Do you like the concentration of magnesium, which is prevalent, 0.5 millimole per liter?
We need more studies for that, but the insights for the higher magnesium is positive, especially that if you find that magnesium is dialysable as well. So if most of the patients coming with the dialysis, you have a removing of magnesium. So we have to build a positive balance of magnesium in the dialysate. I think from 0.5 to 1 millimole should be prescriptive, and still we need more and more effect of higher magnesium.
I ask you this question because I advocate the concept of permissible hypermagnesemia.
Yes.
Because magnesium is the friend for the bone and reduces vascular calcification. This is why I like to shift from 0.5 to 0.75.
Yes, exactly. Yes, and you need monitoring as well, because it's a bi-direction. If you go to hyper or to go to hypo, so you need to manage of that. I think 0.75 is good, but it's not too much in the market.
Yeah. This is a very hot session, Professor Hisham.
Yes.
And I think now Professor Tariq will start the
all our hot topics. Yeah, all our hot topics. Yes, exactly.
And you are updating us with these data. What about inflammation? You've mentioned inflammation several times.
Yes.
So what about sarcopenia in patients with hemodialysis?
Oh, this is a very important issue as well, because I think it's closely correlated to major complications in dialysis. And inflammations and sarcopenia is like a one-way track. If you have inflammation, you mostly will have a sarcopenia. So by definition, sarcopenia is a decreased muscle mass, a decrease in the muscle strength, as well as a decrease in the physical functioning. And it's the end result of multi-variables in dialysis patients. You can find that on inflammation from the dialysate, from vascular access, and you can find that on aging, on patients on premature aging as well, vascular calcifications, and the low protein intake. We encourage patients to eat well on dialysis and do dialysis well. So please don't consider that protein restriction on dialysis. Low physical activity, and sometimes, importantly, due to inefficient dialysis, you are still using low flux, you are still infrequent dialysis, and you are still using very short dialysis session. So these are all one issue that's called sarcopenia, decreased muscle mass, as well decreased power. On the other extreme is the frailty, which is related as well to much more complication than in sarcopenia.
If you allow me, Professor Hisham, I think the best way is to avoid sarcopenia.
Sure.
Because if sarcopenia is developed and evolved, it is very difficult to correct sarcopenia. And sarcopenia is associated with increased mortality. So we should be smart, avoiding sarcopenia by early interventions of nutritional aspects.
Prevention, yes.
Encouraging exercise to keep the muscles.
And I like very much the term frailty and the introduction of frailty in dialysis and in transplantation, you know, because it's not a disease, it's a state.
Yes.
Yeah, this is smart of
yes. It's usually correct as well for sarcopenia. You have a sarcopenia, frailty, aging process, inflammation, all under the same basket.
Exactly.
Let's go back to the innovations in dialysis strategy. I think the idea of implanted kidney and the bioartificial kidney is a very hot issue. And I would like to hear from you about the progress in the wearable and bioartificial kidney.
Yes, thank you for addressing this question. Exactly, the bioartificial kidney had started 15 years ago, and I think it's more or less technically is very difficult to reach the tubular cells and to inform that. And if you look to this slide, the bioartificial kidney, meaning that you have a synthetic dialysis membranes and integrated that into one single layer of renal tubular cells. Theoretically, it's good and started in the acute kidney injury 15 years ago in intensive care, and the results was promising. And accordingly, the cell lining of the renal tubules have the organic anion transporters, and these organic anion transporters permit removal of proteins, toxins, as well from the circulation. But technically, it's very difficult, and I think there is no more clinical research on such integration of synthetic membranes and renal tubular cells. What is really promising is the implantable artificial kidney, and it has an FDA, and this FDA had been reached for the 2 years ago to have very access for that. And if you look to these slides, this is the implantable kidney, and it components of two components implanted in the pelvis and has no power supply. You are using your own arterial blood pressure, and you have even the patient can have micturition because you drain the ultrafiltrate into the bladder. You feel like it's very, very promising, and it's like a cup of coffee. It's just very small, and technically is okay.
So it is very small and not externally connected like the photo.
No,
appears.
yes.
It's inside, simulating the transplanted kidney.
And continuous 24 hours working, and the patient still has the capacity to have filtrate into the bladder. So I think if it's approved from FDA, its clinical research will be on a faster track.
Okay, thank you very much regarding this point. We are living now in the era of COVID-19.
Yes.
What is the reflection of COVID-19 on dialysis practice and the innovations to face COVID-19?
As you know, that the pandemic of COVID-19 affects the kidney as well as the lungs, and in different percentage, from 10% to 25% may have an acute kidney injury. On the other hand, patients on chronic dialysis may got COVID-19 because they have a bad immunity, and the mortality is still very high. So if you go to the dialysis for the patient with acute kidney injury or the chronic kidney disease who catches the COVID, you have to do a convection therapy, because this convection therapy remove the cytokines, and removing the cytokines storm. Interleukin 6 is around to around 17 to 18,000, and easily removed by hemodiafiltration CRRT. If it's not available CRRT, which is lacking in some centers and difficult technicality, you can use prolonged intermittent renal replacement therapy. One example of this therapy is the SLED technique, and equivocal in the result like CRRT. In all the treatment modality for patients with acute kidney injury or CKD5 on regular dialysis, you have to use convection type therapy by high flux membranes.
In the start of the COVID-19, I was totally against plasma exchange to get rid of cytokines. But nowadays, I read some case reports or few reports about the value of plasma exchange to remove all cytokines. Are you supporting plasma exchange or you are against?
I'm against at the moment because if you need to remove cytokines, you need CRRT or hemodiafiltration. You don't need to remove immunoglobulin as well. I don't know, you know that plasmapheresis remove a lot of issues, proteins, coagulation factors, immunoglobulins, a lot. And
Be more specific by removing.
yes, exactly. So the COVID is to remove cytokines, and removing cytokines, you need prolonged and convection therapy, whatever. Prolonged intermittent renal replacement therapy or continuous renal replacement therapy.
This is great. Thank you so much, Dr. Hisham. Dr. Hussein, let me ask you something. What about the recent innovations in phosphorus control in the hemodialysis patient?
This is a very nice question because phosphorus is one of the most important parameters to be controlled in dialysis. And how to control phosphorus is by reducing the phosphate in the diet, but to avoid, we should avoid malnutrition. So we can advise for boiling of meat, cutting meat in small pieces and boiling, and then get rid of soup. So this is a very nice way to allow sufficient protein without malnutrition and to reduce phosphorus by this way.
This is a nice tip. So they should overcook the meat and cut it in small pieces and get rid of the soup in order to get rid of the phosphorus.
So long as you asked about how to cook, to be cooked in the pressurized oven, and the meat to be cut in small pieces, and to get rid of soup, because soup is full of phosphorus.
No additives.
Yes, and one of the very important and crucial is the food additives, because food additives are inorganic phosphorus.
Yes.
The absorption of inorganic phosphorus is 100% with no any nutritional values. The same for cola, because cola is full of phosphate.
Yes.
So we should avoid cola and the additives and the food processing. So this is regarding food. Regarding drugs, the phosphate binders are among the most famous classes of anti-phosphate drugs. All of us are aware by phosphate binders, either calcium-based or non-calcium-based phosphate binder. To augment the action of diet phosphate binders, then the scientists thought of absorption of phosphorus from the intestine. To target the phosphorus absorption from the intestine, we have two important pathways. We have transcellular pathway and paracellular pathway. To target transcellular pathway, the use of nicotinamide was very nice, and it was tested, unfortunately, in combined trial to combine phosphate binder, as shown in this slide, to combine the nicotinamide with the phosphate binders to inhibit sodium phosphate cotransporter. Unfortunately, this trial was negative because of the side effects of nicotinamide. So the scientists are thinking of other drugs that can target sodium phosphate transporters. One of the interesting pathway is paracellular. How to inhibit the paracellular absorption is by targeting sodium hydrogen exchanger isoform 3. So by inhibiting sodium hydrogen exchanger, this will lead to accumulation of protons within the cell, and this will reduce paracellular absorption of phosphorus. It was fantastic randomized control trial. The results were positive regarding the added value of this drug, and the name of the drug is tinabanor, which is sodium hydrogen exchanger inhibitor. The most common side effect is diarrhea. This is why FDA approved tinepanor in treating away from renal failure, irritable bowel syndrome, constipation type. But to recommend the use of tinepanor in dialysis, we need further studies.
This is great. Thank you so much for answering these questions. And what about your opinion regarding green dialysis?
This is a very interesting question. What's meant by green dialysis? Green dialysis is to do dialysis which is compatible with the environment, to save the environment. And one of the important is to be friend with the environment, to reduce the water consumption, electricity, and the toxicity to the environment. So I would like to just to explain the water because as you know, for every session, the patient consumes for the session around 500 liter per session, because as you know, the dialysate is run 500 milliliter per minute. In 4 hours, it is 500 liter. It 120 liters. But to have 120 liters, it consumes more than 500 liters per session.
Yes. From RO, for rejected water, and much more than the produced water.
And for RO, yes, as Professor Hisham mentioned, not all treated water by RO is used for dialysis. There is a proportion of water which is rejected. And by innovations in dialysis machines and in the RO unit, the rejected water is reduced so much, but it still constitute a major fraction.
This so you mean that recycling of the water coming from the RO to recycled again inside the RO. And it's a very magic point. It's very important because in countries or cities we have a scarcity of low income from the water supply. You can improve your product water by recycling. I think it's a magnificence, yes.
Thank you, Professor Hisham. The rejected water is potable water. We cannot drink it, but we can use it in the washing of the dishes, in the garden, in the washing cars. So we can use it. So reusing rejected water instead of being drained, I think it will save a lot of money.
You cannot drink because it's a lot of ions, because it's a rejected water. So it's coming out from the RO, not for the machines, but coming out to the sewage. So you can use it from the sewage for other non-drinkable water. That's a good idea.
To approximate the meaning, it is approximate for doing dialysis all over the world. There is consumption of 270,000 million liter of water. So at a big amount of water per year per patient. So I think if we
try to save it as much as we can and make other uses.
And this modality is applied in France, in many countries. And
we can calculate that here in Egypt because we already have a low water supply. So we can calculate that and put an optional for that, yes.
This is a project. This is good.
Yes, very good. I think this is the end of the session. I would like to thank Professor Hisham.
Thank you very much. It was very my pleasure.
Wonderful statements. Thank you very much, Professor Tariq Fayad, for your questions and interactions. Thank you very much, dear nephrologists all over the world, and we hope to meet again. Thank you and goodbye.